assessment in the clinics. And the speaker for the session is Dr. Margaret Shanthi Francis Xavier Ma'am, Professor Pharmacology, CMC Vellore. She has 17 plus years of teaching experience and leadership in medical education. She is the coordinator of NMC Nodal Center and faculty development workshops impacting 60 plus medical colleges in South India. She is also the author of 25 plus research papers and recipient of CMC's Best Teacher Award 2018. We hereby invite Dr. Margaret Shanthi Francis Xavier Ma'am to address the gathering on the topic.
Good evening. So it's a great privilege for me to be standing here in this place and ASR Medical College. And I also thank the coordinator and the co-coordinator of this institutions, as well as all the delegates and all the students. And my topic is being given as So the designing cases for effective assessment in the clinics. So something is a skill to create scenarios, the real life scenarios, align your teaching learning objectives to a teaching learning methods to an outcome assessment. So this is a current scenario of what is happening. Like we use, so there are so many tools are available, but we use a single tool. And this photograph is very common in medical education. Everybody uses photograph, the slides in the assessment, because if you're going to check the students during the university exams or in a format you are submitted with only a single tool, then it is not going to be fit. You know, we cannot judge the student how good, how well they are in assessing the student. So you should have a multiple tools can be used in the assessment. That's what my topic is also. So this is one size does not fit all. This beautiful article is there. And I think that I put up the articles there. So the framework and resource for individual interventions for a struggling medical student. It is not one tool is important. Sometimes students are average, below average. Sometimes they are very quick to understand. So there are different, you can see the different vehicles are there, different speed they can go. So as a teacher that we should remember the importance choosing the right assessment methods in the clinical skill evaluations. So we use, I think Dr. Stephen sir also used the Miller's pyramid. Medical education always goes with a pyramid, and this is a pyramid that knows how, shows how, and does. Knows from the recall type, maybe an MCQs in the recall type or short notes in a recall type. You can go a little bit higher, that all belongs to cognitive, maybe an extended matching or a case-based scenario. Or you can go into the behavioral type, shows how, maybe like an OSCE demonstrations. Then you can reach to the DUS level in many clinical examinations. So you can go till the DUS level in applications. So the Miller's pyramid can take us from the cognitive level to the behavioral level. So when it comes to the objectives of my class at this point of time is to use a standardized assessment method in whenever you're doing designing the clinical cases and align with your teaching learning methods, and within assessment promote the critical thinking and the problem solving. It's very important. That's what it is. It is something a unique, is a skill. That itself is a skill, making a good scenarios which align with your objectives and your assessment outcome. So develop the cases that accurately assess the knowledge, decision making, skills and practical applications. Create a scenario that challenges learners to analyze symptoms, interpret data, and also making them inform the clinical decisions they make it once they read the scenarios and apply the knowledge and the decisions how they can treat the patients. So we need to choose the right assessment tools. So I think sir has already talked about reliability, standardize and validate. All these are important. So your competency, what you wanted to check. There are, NMC has given so many competencies for us. So which competency that you wanted to check, what will be your objectives. So you have to break down your competency, what particular domains that you wanted to do it, and then your learning methods, in what way that you are going to do the learning. So the three pillars in medical education, one is that objectives, learning strategies, and also evaluations and feedback. So previous speakers also talked about the assessment will not end up without the evaluations and without the feedback from the student, and we give a feedback to the student. So assessment and learning is very important. The assessment drives learning at 4 ways. One is content, format, timing, and feedback, which mainly we use in many clinical examinations. So the assessment drives student learning. It's by Dr. George E. Muller in 1990 to 1998. So the domains, we keep talking about the different domains. The domains of knowledge, that is cognitive. The domains of psychomotor is more on to the motor skills. And the domains of an attitude, affective or communications. So these are the different domains that we use it during an assessment. And I'll give you the 2 scenarios. The first scenario, just have a look at it. The first scenario, the examiner 1 and the examiner 2. There is only one case, diabetic mellitus, and one case, a patient with diabetes mellitus, and you can see that 30 minutes for a long case. The decision is either pass or fail the student. And the total timing that is given is 30 minutes. This is the scenario 1. Only one case, 2 examiners, and each examiner have to give marks to the student. And this is the scenario 1. If you go to the scenario 2, that is B, there are 4 examiners are there, as in right now in a university we do have a 4 internal and 2 internals and 2 externals, and we have examiner A, B, C and D, and then you can see examiner 1 have a diabetes mellitus, examiner 2 have rheumatoid arthritis, examiner 2 have an asthma, and examiner 3 will have a stroke. So, and each examiner has been given 15 minutes for the student to evaluate or assess the student, and for each as a long case, the decisions here will be fail or a pass, and then the total timing that has been given is 60 minutes, and each examiners will be doing it in 15 minutes time. So I just wanted you to think about the scenario A and scenario B. What would be good when you are doing an assessment? So the assessment clinical case, we use a blueprint and we use the domains where we wanted to give the weightage, and all the examiners or different domains and different weightage are being given. And then now as a chairperson, as you as an examiner, you have to think the particular candidate is known to be weak in diabetes mellitus. So that means he definitely is going to do it bad, because this is 60 minutes and 30 marks for them is being allocated, and the case is only one single case. But at the same time, when you see the scenario B have a multiple cases, the multiple domains. So even if the students wouldn't have been good in one, but they will be good in the other. Maybe in rheumatoid arthritis or in a stroke or in asthma, it must be good. So which one will be good? So if you ask me, it will be definitely, we should have a multiple tools, multiple domains to be assessed, not a single. That's why we need a blueprint, and we make sure in our high-stake examinations we can assess multiple domains and multiple assessments, so that it will be good, so that we use multiple tools, not just only theory, not just only OSCE or multiple choice questions. So there are different things can be assessed in that. So the content specificity is also very important. So there is no generic problem solving the skills. There is a lot of, like it says that it is the generic problem is like a lock, and the skill is like a key. So not all the key can fit into the lock, only particular key can fit. So even the if you have been diagnosed me as an diabetes mellitus, I may not be the first generation's drug, may not be good, I may have to go into an insulin. But at the same time, for other person it will be good. So the problems and the skills, both are different, but we must know where the criteria, the typical correlations to the skills across the problem with the ratio of 1 is to 3.1 and 0.3. So both are different. So that's what I put it in such a way. The management of diabetic ketoacidosis is a different problem. How you manage is more on to the communication. Sometimes people are so good in communications, they may really do it well. But and then you can give it for another person, same thing, outpatient management of diabetes mellitus. So these are the different skills that you can put knowledge versus maybe some it can be a cognitive, or it could be a psychomotor or affective or a communications. So there are different problems are there, and the skills are also will be given. So whenever you do an assessment, you have to match. The blueprint should have a cognitive, the blueprint should have a psychomotor, the blueprint should have an affective, communications, behavior, etc. So the educational impact and the feedback plays an important role. Any test is an anxiety and provoking for a student, especially for the anxiety for the student or a staff. Test has a potential positive effect, as a negative effect is there on a learning and a professional development. Provisions of feedback should be strongly emphasized and consider a performance-based assessment. It's so important. Whatever we do it, at the end, the feedback which motivates a student to do better. So linking learning and assessment is another triangle where you do a learning and then you do an assessment, and once you do an assessment, there is an evaluations, and then there is a feedback. This is a cycle which goes on. So concept of mastery, all or none state, not always, right? Not really. Sometimes we cannot say the exam students will pass if they don't know how to do a CPR. They have to do, they have to be competent. They cannot be 9th step they can do it and the 10th step they don't do it, or the 6th step they don't do it but the 9th step they do it. Either they should be good, or they should know all the steps, or they cannot pass. But it's not in reality. Sometimes due to, you can see the dots, though we make sure that the students fail, or even the feedback, later it's not that they will stay in the low line. By improving that repeated feedback, may sometimes improve the student, right? That's what you can see at the end. They achieve, they be a good Indian medical graduate. They know all the steps. They know how to resuscitate a dying patient in a CPR. But during, when you are assessing the patient, you can't just give out of 10 marks, okay, 9, maybe doing it well and passing the student. No. We must make sure the student have to do it well, because all the steps are important to resuscitate the patients. But then the dot step will indicate the student have a multiple feedback, motivated the student, make sure the student do the right step. Finally, before going into the final exams or before finishing as an Indian medical graduate, they are know all the steps very clearly. So the continuum of the clinical competency, student, trainee and doctors in practice, which keep moving on in their life. So there is a continuous assessment. You can see the arrow. May not be doing it that well, but then in the due course they will become competent. Alone they can resuscitate the patients and do all the steps in CPR without even missing off one to resuscitate and save the life of a patient. So choosing a tool should be, first of all, should be valid. Whether does it really measure what is to be measured, and reliability, does it measure consistently. Any tool that we use, it should be a consistent, it should not be just only one time. And education impact, does it have an education impact on a teaching learning, and acceptable, it is really acceptable to all the stakeholders in our department, people who are working, the staffs as well as the students and teachers also. So that is an education acceptable and doable. Its infrastructure is there. It's not every institution have a simulations or a skill lab, but then it's all doable. We have to look into it. So these are the things that we keep that in mind, and it should also be cheap. Whenever we do choosing the tool, it should be cheap, which be affordable for our institution. So we should think about it, which tool be affordable, how are we going to use it. So the current traditional way, what we are doing it is in a long essays and a short essays. That's what's happening in our institutions. A student needs to take a history, general survey, and then systemic examination, come to a diagnosis. It's very subjective. That's why it's written largely some of the things that we missed it. We are not observed on that, right? We missed it, but then we just here and there we ask the student what will be a diagnosis. That's all. There is nothing happening. That morning I think Dr. Krishna Sheshadri was talking about it. Examiners sit in one side and then students will do it. The examiner don't know how the student, probably sometimes depleted patients also will tell the diagnosis, no, I am having MR or this is an arrhythmia, so whatever it is. Student, the patient itself sometimes tells. So as a teacher, as an examiner, so that happens, that's a way of a traditional happening it. And the short essays, short case also, it will be come to a diagnosis. They give 15 minutes, a small case, and come back to a diagnosis, and 20 minutes and 10 minutes for presenting, and 5 minutes for asking questions. And then largely some of the things, important points we unobserved in that. So what will happen? Usual queries happens in the long and the short. Current traditions way how our exam patterns are long essays and short case and long cases. It's like this. What is your diagnosis? This is a case of XYZ. How do you manage? What are you telling? So how do you manage? That's all. How you see the pulse, or how you come, what is the heart rate, or what's the pulse, nothing. We don't come into it, whether it is a hard swelling or a soft, or you heard a murmur. So nothing, we just come into the diagnosis and we do an assessment for these students. So there are OSCEs are there. OSCEs are mainly for the skills. So each student is exposed to all the stations. These are the different assessment that can be used in the clinical cases, and then checklists, having specific learning objectives, and then you can have more than 20 stations, 18 stations if you have a good resource. You can have good rooms and good faculties are there. You can have multiple domains, multiple topics, multiple system can be done it in OSCE stations. This is the way OSCE can take in place. So now I come back to some of the things can be done in designing the clinical cases. If there is no patients, we can have a paper case also. You can have an elements of clinical vignettes cases, then age, gender, all that you can put it, and then you can have a small scenario. A 23-year-old person come to slow growing mass on a neck in the past 3 months. You can put us in a real life scenarios, and then which are the following the most likely diagnosis on these patients. So, or which anatomical structures are being involved. If you wanted to go into the knowledge of the anatomy, you can also ask. Or you wanted to go into the next level of physiology, so you put a lead question what you wanted to do it. So the clinical vignette can also be used multiple times. In the same scenarios, you can have it a single jump, double jump, and triple jumps. So in a single jump, I just put it up to you. You have a scenarios like this. The old man comes a physician because occasional shaking of his right leg, arm, and the leg at rest. He has 2 years of history, slowness, and difficulty in using his right arms. And the patient's face is lacks expressions. His face is soft, and his posture is stooped. And which of the following is most likely diagnosis? That will be a single jump, right? A single. So you can have a continuations in that, maybe in the room number 1 with this case. The same case can go into the room number 2 with the lead different, and the same will be in the room number 3 with the lead different. So which are the following likely to be diagnosis in this patients? And then second, the same scenarios, these findings are more likely to caused by lesion in which of the following locations. So you can ask the student, if they are wrong in the beginning, they will be wrong in the diagnosis in the double jump. If they are wrong in the double jump, single jump and double jump, they will be wrong even the triple jump also. So again, you can have the same scenarios. The most appropriate diagnosis and pharmacotherapy of the patient is most likely to produce the following side effects. So I just in pharmacology, I brought up the side effects. As you are doing it your own specialty, you can give your specialty things. You can have in a single jump, double jump. You can take up your specialty and create a scenarios. So you can correlate with the phase 1, maybe anatomy, physiology, biochemistry, or micropath and pharmacology in the second jump, and the third jump can be the clinical applications. Can be done when you are designing the cases. It's not that it's always a bedside. We can also create the scenarios on our own. So, and interviewing skills is also a good. We can have one station on interviewing skill. That's very good nowadays. It's happening. So, a case scenario has been put up. Which of the following question is most appropriate that you ask the patient first? So, you put up A, B, C, D, and we think that maybe where is your chest pain located? That must be the appropriate how the student approach the patients. A scenario, an emergency scenario, what will be the first lead question for a student? So when the lead question has come only, then you can go into the next one, the management, the treatment plan, and all the lab and everything goes on. So if they are wrong here, they will be wrong in everything. So it is an interviewing skills. And you can use a different media of the clinical vignette. You can have a computer-based, AI-based, computer-based, or ChatGPT. Anything can be done. You can have an assessment of knowledge and skill. It should be an authentic, and assess the skills, and then avoid giving the answer away. The descriptions, that's also very important when you use the medium. Select the media that best stimulate for that particular scenarios, and which happen in a practical, that means in a real life scenarios, that should be an appropriate. So the types of media that can be images like X-rays, MRI, CT scans, and you can use PET scan or anything. Images can be done, and patient's photograph with the consent can also be used, and videos in practice and interactive media. So you can also use when you're designing the cases. It's just not, if you wanted to use a different tools, just not only the the patient or a scenario related to the patient. You can use the knowledge wise, how the students having the particular case, how much the knowledge they are. They may be good in baking the cake, but they may not be good in baking, in doing the making a pista, right? So you can have a different taste, right? You can do it a different media. So here I put it an example. You can just use an X-ray, interpret the studies and decide on a diagnosis and a management plan. You can show the X-ray, you can show the CT, and ask the student what is exactly that you diagnose and how do you manage. So you can use the different types of media when you're designing the cases. Interactive media is something is very interesting. You can have a scenarios if it's going to be a cardiovascular system or anything, even in respiratory, pulmonary pneumonia, you can use it. So you put a scenario, click the red circle, here the cardiac, this is something related to the murmur. So I just put a scenario, click the red circle to hear the cardiac examinations. Which of the following the most likely finding the cardiac auscultations and stimulations? You can use this also, but you must have, this thing should be available. It's kind of a simulations management should be available, then it's easy to do it. But you can have stations in that also if you are going to use cardiovascular systems. I'm just putting a short answer questions and essay questions. You can have a case-based scenarios. Sorry, this the previous one was just a case, and then you can have in a sequence of based on to the case, you can have a questions that is different tools in essay or a short notes. You can do it, and then you can have an ECG designing the case. You can have another station, so that if you only going to use sometimes only the cardiovascular system going to be an assessment, you can have a case. You can have a media. Different media can also be used. You can use even the ECG. The knowledge level, this can also be checked. So you can have an ECG findings and ask them to identify the ECG finding, name the drug for conditions for this particular diagnosis. The students are correct, then the management of the drugs also will be correct. So you can have some kind of a weightage for the marks, just not only for the long essays, long cases and short cases. You can break down the marks in a different way so that the assessment will be covered in every area, just not one particular thing. And the 4 cardinal principles in assessment and medical education, there are 4 principles are there. The first principle is sound knowledge, the basic knowledge they should have it. Second one, there will be knowledge as well as they must know how to do a performance. As I said, there is a case, but if they are not using the appropriate skill for that case, it is fail. They must know, their meningitis a case they identified, they must know how to do a lumbar puncture. If they are not have the skill to do it, then how do you diagnose it? How do you find out the laboratory and then treat the appropriate antibiotic for that patient? So it's very important. So knowledge and the performance is also important. And the third principle, multiple domains. It's not a single domain during an assessment. It should have a knowledge, psychomotor and affective, and communications are also should be given importance. And the mastery of knowledge, all or none. It's very important. It's either they know all the steps or they should given motivations and evaluations and feedback and make sure they achieve all the steps before they leave the final exams or pass and going as a good Indian medical graduate. So the workplace-based assessment is also important as the knowledge, the doctor, how competency and performance in the professional practice, competency assessed through the relevant clinical tasks after stimulated and occasionally distant from the workplace, and assessment competence as well as the performance of the students. That's a routine behavior. So workplace-based assessment assess dust level of Miller's pyramid. Maybe in clinical we must keep climbing from nose out, shows out, and dust. Always goes into the application. All that can be 360-degree feedback. All that can be identified in a workplace assessment. So the classification scheme of a workplace assessment, you remember that the outcome of care, the process of care, and the practice volume. This is the basis of judgment. In that we have a clinical records, we have administrative reports, we have a diary or a logbook, and we have an observations. These are the methods of collecting the data. That is how we classify the schemes of the workplace assessment. And the tools that we use in the workplace, one is a DOPS, that is directly observed, and second one is case-based discussions, third one is a programmatic assessment, and then mini clinical examinations and mini peer assessment. So these are the different tools that can be used in when you are designing the cases. So now we come to the direct observational procedure. That's daily we do it in our clinical setup. It requires the student undertaking any of the procedures and judgment about the specific component, maybe very specific domains that you are going to check, and grade the students. But there is a lot of checklists are available in the Google. If you put a direct docs forms, everything will come, but what specific that you wanted to check, you can download it or you can make it and validate in your department. The strength that evaluations and the direct feedback is to be given. Weakness and limitations, that is expert observer, assess, evaluate the procedures and give the feedback to the student. And case-based is a variation of chart simulated recall, that is essentially a case reviews and particular aspects of the case that involved to explore underlying reasoning, ethical decisions and decision making. All that will come in a case base and can be used variety of clinical settings, and that can be used in the clinics, wards and ICU, etc. We can use this. And also you can assess the 7 clinical domains. What are the 7 clinical domains? You can see clinical domains on medical records, clinical domains of assessment, investigation and reference, and treatment, follow-up and future planning, and professionalism and overall clinical judgment. All these domains, and this case-based assessment also is there in the the case-based discussion is also forms are available in the Google. You can download it, which is feasible and which will be a property that you can use it in your own institutions. You can use it and you can validate. So you can use 7 clinical domains. You can do it. And then programmatic is something which is coming up right now. So approach one is a comprehensive evaluations Clinical practice arrange the diagnostic, range the diagnostic test, and programmatic multiple assessment tools to get a comprehensive picture. There are multiple assessment tools that I put it so you can get a clear picture. Continuous monitoring. That is, you can see in the clinical practice whether the patients are continuously monitored by our students and track the progress and adjust treatment. Today they come and start with the penicillin. Tomorrow after the lab report, penicillin will not be sensitive. There will be other antibiotics, so whether they're changing it or the electrolytes, it's not very less, and whether they're changing the report. So that can be the continuous monitoring can be done. Data-driven decision making. Clinicians use the data from a diagnostic test, whether the diagnostic test has been appropriate, and the programmatic assessment, the various assessment tools used to inform decisions about the learner progressions can be done. And focus on improvement. If the patient started improving from the diagnosis and all the treatment and the lab, everything, when the patients improved, improving learner competency and the performance can also be, it will go into the assessment folder. So this looks like this. So the translations to an assessment practice, you can see it. There will be analysis will be there, learning goals, mentor meetings. Make sure that all this should be available. Formal assessment tools, inform assessment results, individual collectible transcripts of meetings, retrospections on past learning goals, prognosis. All this in the mentor meetings you will discuss. So all this will be there. Goes for an analysis, go for a learning goals, mentor meetings, and then you look into it. These are the translations to an assessment practice. So coming back 1 minute. Okay. So the mini clinical evaluations. Now I come into the main thing to the DUS. What we can do it, because in a clinical setup, we can take the students to the DUS level of an evaluation, that is mini clinical examinations. The workplace assessment can be done, and the student can be judged more than 9 domains. I will put up what are the 9 domains, and the clinical domain, same thing like what we said in the case base. Here also medical interviewing skills, that's one of the skills, how they talk to the patients. Second, physical examination skill and professionalism, the way they handle the patients, and clinical judgment, counseling skills, and organization and efficiency, and overall clinical competence, communication skills, and use of a diagnostic test. All these are the different domains in a mini clinical examinations. You look into all this, and there is a form available. I think the first day they put up, yesterday pre-conference they were talking about the different forms are available, and there are forms are available in the Google, and you can download it, and you can have all these, have the rating scales are there, and you can use it. So now I just put up a small scenarios how you can use this designing cases as an effective clinical practice assessment. One is a case is setting in emergency department in a Christian Medical College. Trainee is a medical PG and evaluated as a consultant of the professor. The patient's presentation, a 55-year-old male present with a chest pain that started 1 hour ago. The pain is central, crushing, radiates to the left arm. He has an history of hypertension and diabetes. No prior history of a heart disease. This is just a scenario. So with this scenario, so this just like a paper case, you remember it, or the patient's in a real life scenarios also, doesn't matter. A paper case should be a real life scenarios. And clinicians observe a postgraduate resident conducting the patient consultation assessment focus on 9 domains. I put up the 9 domains. We can look into the 9 domains whether my student is doing all this to assess that. So first, medical interviewing skills. So the resident asks clear questions relevant to the chest pain, and including the durations and the nature of the pain, and explore the risk factors of the patients. If there is an MI, what are the risk factors? Can be a smoking or a patient on an alcoholic or any family history of MI, whether the questions are direct and then uses open-ended questions so that he gets more specific to the diagnosis. So this is kind of interviewing is a skill. Is everybody develop that as a part of a skill, then only they can come to a right diagnosis. Then the physical examination is the next domain, whether the student for that case, whether the student performance a systematic cardiac and respiratory examination, a pulse rate, heart rate, etc., and respiratory rate, and checks of vital signs, and auscultate the heart and the lungs. So these physical examinations are appropriate for the case that is being given to them. And professional shows respect and empathy towards that, and maintains confidentiality and ensures the patient's in comfort. Right? All these are the how you assess the student. And then clinical judgment. Whether recognize the high probability of acute coronary syndrome, the clinical judgment, whether this is something that I look forward to this coronary syndrome, orders an urgent ECG, urgent cardiac enzyme appropriately for the case, when it is being given to the student. That is a clinical judgment. And they're all rating scale, okay, from 0 to 5, the rating scales are there. And counseling the patients, explain the potential diagnosis of needs, and also for further tests in simple terms, and reassures the patients without creating an unnecessary anxiety for a patient. And organization and efficiency, this is also a skill, it comes under the domains. And quickly prioritize the urgent management for the particular coronary syndrome or MI, and delegates task effectively, requesting an ECG while preparing for an admission. How quickly the students do all this. So this is an assessment. And overall clinical competency is good. Or communication skill, engage with nurses, that is 360-degree feedback, whether engage the nurses, the other students or other junior people in the ward, and maintains a rapport with the patients and with the patient's family. All these are the communication skill you should be rated. And use of a diagnostic test, appropriately orders the right test. Sometimes we order, sometimes we just tick, so many costly tests which can be diagnosed by clinically itself. We have to, as physicians, we must make sure that all these tests are really needed or it could be avoided, because unnecessary overburden for a patient. So avoids unnecessary tests and ensuring a cost effective. So all these are the assessment where there is a different rating is there with the students done that can be done in a many clinical examinations. So 360-degree feedback is the important in when we are doing an assessment, designing the cases. One, who are the evaluators, the peers, the subcoordinate, your teachers, the student, patients' relatives, and sometimes administrators. They're all 360-degree feedback should be the part of it. They're doing the assessment. To summarize it, creating the realistic scenarios is a skill, right? And the challenge of learners to apply their knowledge and skill in the practical settings. And cases should be designed in such a way which range the abilities, including the clinical reasoning, diagnostic skill, and the management approaches, and structured to provide a feedback for the student. It's important. Evaluation alone is not important. A continuation feedback, all or none, but not really. Remember that to be master. They may not be good, but it is not always they fail. They will definitely show improvement, may not be that in beginning, but before they finish the academic year, they will show the mastery of that. So the continuous feedback and facilitate a continuous learning ultimately improve the clinical competence. So this is the references, and these are the things. So thank you so much. Any questions?
Sir, Professor and Head of the Department Biochemistry, Principal NRH Chinakakani, to present the memento.
Let's now move on to the most engaging and intellectually stimulating part of the conference, the debate session. The topic for today's debate session is standardization versus personalization in medical training. Should medical skill teaching, learning and assessment be standardized for all or adapted to individual needs? We hereby invite the moderator for the debate session, Dr. Vinay Kumar Sayeli Sir, Professor of Pharmacology, Ashrams, Eluru.